Okay, I'm going to help guide you through the lesson and the readings this week with this quick little video. Well, I don't know how quick it'll be. You know how I am, I tend to talk a lot. So let's start with talking about upregulation and downregulation. These are important concepts when we're talking about endocrine disorders because there are various things that happen in the body that either upregulate receptor sites or downregulate them. So upregulation of receptor sites is an increase in the number of receptors, hormone receptors, over a period of time. And downregulation is the decrease in that number of receptors. And the body adjusts those things according to different scenarios that happen in the body. Now remember that there are multiple different kinds of hormones, and the two major classifications are fat-soluble hormones that go right through the phospholipid bilayer, and water-soluble hormones are proteins that have to attach to a receptor on the membrane. They, in turn, cause a second messenger to be released intracellularly that then creates a cellular response. So water-soluble hormones themselves do not have a direct effect on the cell. Rather, they hit the receptor on the cell membrane. That produces a second messenger inside the cell that then generates the cellular response. So when there are abnormalities with hormones, they happen for one of several reasons, and we can sort of classify them into these two broad categories. One is an abnormal amount of hormone, and the other is some problem with the target cell. The target cell is broken and it can't understand what's going on with that hormone or what it's supposed to do. There's another option where there's an abnormal hormone that is produced. We don't see that very often, and we're not going to talk about it here. So too much or too little hormone happens when there's failure of the feedback system. So remember the positive feedback system, which is where there's a hormone produced that exerts an effect, and a negative feedback system where an excess of a certain hormone produces a downregulation. So those two, or that failure of the feedback system is one of the things that can cause too much or too little hormone. Dysfunction of the endocrine gland itself can cause a problem. So if there's an autoimmune disease affecting the thyroid gland, for instance, it may not be able to produce T3 and T4. Again, the altered hormone, we're including that here in too much or too little, but there could be a hormone that is improperly formed. And then, of course, ectopic hormone release from other sites in the body that aren't supposed to produce that. Target cell dysfunction falls into either receptor-associated disorders category or the category of intracellular disorders. And they are specified here for you to look at in more detail. So let's get into it and talk about some of the actual problems that we see occur in the endocrine system. And we'll start with understanding how this hypothalamic pituitary axis works. Remember that the hypothalamus produces or contains these nerve cells that go down into the posterior pituitary gland. And essentially what happens in the posterior pituitary is these neurons secrete a hormone that gets stored in the posterior pituitary. That's exactly how that works. There's not the posterior pituitary does not produce the hormones, it just stores them. On the anterior side, however, it's a little different. So in that sense, the hypothalamic nerve cells communicate with the pituitary and tell it to produce these other hormones. So there is, for instance, with ADH, the hypothalamus senses that there's whatever level of water in the bloodstream, and then it sends the requisite amount of ADH to be stored here. With, let's just take the thyroid, for instance. The thyroid produces T3 and T4. When that T3 and T4 concentration are sensed by the hypothalamus responds by adjusting the amount of TRH, okay, thyrotropin releasing hormone. And what that does is tell the pituitary to produce more or less TSH. So you see there's two different mechanisms. In this case, there's only one hormone. It's produced by the hypothalamus and stored in the posterior pituitary. For the anterior hormones, there's a hypothalamic hormone that's produced that causes a response in the anterior pituitary, which produces the pituitary hormone. So it's a two-step process for the anterior. And you can look here and see what all the hormones are and refresh your memory about that. The other thing that you should know is that there's a important vascular supply. This is also a portal circulation where there's an arterial supply and then a venous supply that is independent of the general circulation, right? So this portal system that forms around the anterior pituitary circulates blood just within the pituitary gland itself. And that's important when we talk about causes of abnormalities in the pituitary gland later on. So the two, remember, these are the ADH is a posterior pituitary hormone. It's stored in the posterior pituitary, and it can be hopefully normal, right? Normal concentrations that regulate the correct amount of water in the bloodstream. But you could have diabetes insipidus due to decreased ADH, or you can have inappropriate secretion, or SIADH, where the ADH levels are elevated. Take a look at this table so that you understand the differences between diabetes insipidus and SIADH. SIADH, of course, is where the antidiuretic hormone is abnormally high. That means there's not a ton of urine produced, right? There's more water retention, and that's reflected in the blood chemistries. So the the sodium level gets low. It goes below 135 because it's diluted. The sodium is diluted by the retention of all this water. Also, the osmolality, that is the concentration of electrolytes in the bloodstream, goes down. And those have important contributions to the pathophysiology that occur. The weight gain, the hypervolemia, and all of those things, but also the amount of fluid that leaks into the periphery, right? Because the osmolality, the serum osmolality, is what holds what allows the fluid to leak out of the capillary system. Remember, proteins in the bloodstream hold fluids in the bloodstream, and the concentration of ions in the bloodstream is what allows the fluid to move out of the bloodstream. Diabetes insipidus, opposite story, right? There's an insufficiency of ADH. There's not enough ADH produced or released into the bloodstream, and therefore the kidneys don't hold on to water, and they produce far too much urine output. Another thing in the hypothalamic pituitary axis that I wanted to point out is, because you may see this clinically, is hyperpituitarism. Gigantism or giantism is what we see in children and adolescents, and everybody remembers the Guinness Book of World Records that you got when you were in elementary school and you paged through it fanatically and you saw the pictures of the 7 foot tall fifth grader. That's giantism from hypersecretion of growth hormone. Of course, we don't see that in the US anymore because those problems are identified early on and corrected. Acromegaly, though, is where adults can develop a hypersecretion of growth hormone. And that is associated with pituitary adenomas, which we touched on last week. This is a picture of a gentleman with acromegaly, and you can see the squared off features that he has. The squared jaw, the high forehead, those characteristics are very rough. Now, here is a woman who developed acromegaly, and her acromegaly development is pictured here from age 14 until 28. So over this 14-year period, you can see the development of these sharper features until she has the classic look of acromegaly here. So this is growth hormone abnormalities, hypersecretion of growth hormone that occurs in adulthood rather than childhood. Prolactinoma, this is the one of the pituitary tumors that can occur. And if you see right here, so this is the pituitary gland, and right above that is the optic chiasm. And remember, anytime that you have pressure exerted on the optic chiasm, the resultant change in visual fields is loss of peripheral vision, right? That is the classic finding. And of course, this draconian measure here in this horrible looking brutal tool is actually a very nice way to get to the pituitary gland, because you just go right in here through the sinuses and directly into the sella turcica, and they can take out the adenoma that way. Rather than having to crack open the skull and go in, and it's impossible to get to that way. All right, so prolactinoma is just one of those tumors that can cause visual changes like this. And this is the breakdown. This is a little more detailed than what you saw in the textbook 2 weeks ago. Sorry, not last week, 2 weeks ago. But remember, the optic chiasm lesion causes this loss of peripheral vision or tunnel vision. And then other visual changes are caused by lesions elsewhere along the optic tract or the optic radiations. So let's talk now about the hypothalamic pituitary thyroid axis. We'll add another gland. Way to think about this is that the hypothalamus and the pituitary gland have equal responsibilities in maintaining the level of circulating T3 and T4. When everything works perfectly, the central nervous system produces inputs that tell the hypothalamus how much TRH to produce, right? And this is an important component, because you might think, well, why is it that the hypothalamus gets involved and it's not just the pituitary that regulates production of T3 and T4? Well, the reason is because the nervous system wants to have a voice in this too, right? There are components of the nervous system that will be able to influence the production of T3 and T4. Because what is T3 and T4? What do T3 and T4 do? Well, they regulate metabolism. Well, does the brain have some sense of what's going on in a metabolic process? Well, sure, because the higher the metabolic rate, the higher the temperature is, etc. So the brain gets input from these changes in metabolic activity and influence the production of T3 and T4. It's a long way to go, so let's keep going. So the hypothalamus then secretes TRH, right? Thyrotropin releasing hormone, and that goes to the anterior pituitary. And the anterior pituitary says, all right, now I've been told that the brain tells me that I need to make more T3, or that the thyroid needs to make more T3 and T4. So the way I'm going to do that is I'm now going to send a signal to the thyroid gland to tell it to do that. And so what it does is it produces TSH, thyroid stimulating hormone. Okay, that gets to the thyroid gland itself, the target organ, and the hormones T3 and T4 are then produced. And it's the T3 and T4 that have a physiologic effect at the cellular level or the tissue level. Okay? So that's the positive feedback. That's the way that the hormones stimulate production of T3 and T4. Now, let's say that your body is humming along just perfectly and there's no more need for T3 and T4. We need to stop production of that or slow it down. Well, the way that works is the T3 and T4 circulate in the bloodstream and are sensed by the anterior pituitary gland. And so the anterior pituitary sees that there's plenty of T3 and T4, so it's going to use this negative feedback to slow down the production of TSH. Simultaneously, the T3 and T4 are going back to the hypothalamus, and they are telling the hypothalamus, hey, we got plenty of T3 and T4, so I'm going to slow down production as well. And that's the negative feedback loop that's so important. That's the negative feedback loop that's so important. Because without that negative feedback loop, the hypothalamus would just crank out TRH all day long. And that would cause the anterior pituitary to just crank out TSH all day and all night, right? And that would mean that the T3 and T4 levels get super high, and then you get thyrotoxicosis and you die. We can't have that. So what happens when there is a dysregulation of that very complex but yet very beautiful, simple method? Well, these manifestations can happen. On the left are the hypofunction, and on the right are the hyperfunction aspects of thyroid disease. Now remember, in any endocrine process, there can be primary diseases or secondary diseases. So a primary disease, a primary endocrine disease, is dysfunction or disease of the gland that produces the end result anyway. All right. So in this case, the primary thyroid disease is where there's an alteration in TH, which is thyroid hormone, T3 and T4. Okay. Secondary conditions are where there's an alteration in the steps behind the actual production of the hormone. And that means, in this case, there's an alteration in TSH or TRH production. Okay? So primary means it has to do with the end gland that's producing the end result. So in the adrenal glands, it would be cortisol. In the thyroid gland, it's thyroid hormone T3 and T4. Okay? Secondary thyroid disease is where there's an alteration in TSH or TRH because of some problem at that level. And that applies to all endocrine diseases, that nomenclature, primary and secondary endocrine disease. So, how can hyperthyroidism happen? Well, there's really these 4 ways. One is Graves' disease, where the receptor sites are affected by this autoimmune disorder, and there's excess reception of TSH. Okay. TSI is the thyroid stimulating immunoglobulins. And what that means is that there are these immunoglobulins that circulate in the blood because of this autoimmune disease that that the thyroid gland picks up and produces extra thyroid hormone with. The second kind is toxic multinodular goiter. That's where there's just disease of the thyroid gland here that produces excess production of thyroid hormone. There can be follicular adenoma or a cancer of the, let's call it a neoplasm of the thyroid gland. And then fourth could be excess exogenous thyroid hormone, right? So it could be that they're taking too much synthroid, for instance. So the way hyperthyroidism works is that there's elevated thyroid hormone and suppressed TSH. Does that make sense? So think about it. There's some reason that the thyroid is producing too much T3 and T4, not sure why, or the patient's taking too much thyroid hormone, and that signals to the hypothalamus and the pituitary gland that there's an excess amount. So the hypothalamic pituitary axis starts to shut down production, right? So the more thyroid hormone that's circulating in the blood, the more it is sending that negative signal to the hypothalamus and the pituitary gland to shut down production of TRH and TSH. And that's why we get these super low values of T3 and T4 that's why we get super low values of TSH when there's an overactive thyroid. Okay? The way that we can figure this out is with a diagnostic test that uses radioactive iodine, because we can scan for radioactive iodine. So what we didn't talk about is what the thyroid is really good at. We're all really good at something, right? Like my job is teaching and seeing patients, but what I'm really good at is laying on the sofa and eating pretzels, watching football, right? That's what I'm really good at. Well, the thyroid's job is to regulate metabolism, but what it's really good at is concentrating iodine. That's what it does better than anything. And in fact, every bit of iodine that gets circulated in the bloodstream gets picked up by the thyroid gland because that's what it's good at. So we can use that to our advantage, use a radioactive form of iodine that can be taken up in the thyroid gland and then imaged. So we can see if there's low uptake, then that's a thyroiditis kind of thing, or there's exogenous thyroid hormone. And if there's normal or elevated uptake, then that is one of these pathologies: Graves' disease, toxic multinodular goiter, or toxic adenoma. Okay? That's just a cool way that we can figure out the exact etiology. So remember, thyrotoxicosis, overactive thyroid, 100 years ago, it was universally fatal. Now, if we can deal with it in quick time, we can avoid those horrible toxic effects of it. Graves' disease, the autoimmune disorder, is the thing that causes that exophthalmy, where the eyes sort of bulge out, the double vision, and the pretibial myxedema. This is just an image of nodular thyroid disease showing up on one of those radioactive iodine scans. I'm sorry, I said thyroid toxicosis was universally fatal. I meant thyroid storm. This is like thyroid toxicosis on steroids, right? This is hyper acute and life-threatening. But we don't see people dying from that anymore because we can fix it with some medications and surgery or obliteration of the thyroid gland. So hypothyroidism, when it's extreme, we call it myxedema. And when it's super extreme, we call it myxedema coma. And the mechanisms are shown here. You can figure those out based on what you know now about thyroid disease. Remember that when we see hypothyroidism, the way you'll recognize it in most cases is the TSH is super high because the thyroid gland, the pituitary gland is trying to stimulate production of T3 and T4 in the thyroid. And so it just keeps bombarding the thyroid gland with more TSH. But the thyroid gland is broken and it's not listening to those signals. And so the TSH can get really high, but the thyroid gland can't do anything about it because it's broken and won't be able to produce the T3 and T4. Secondary hypothyroidism has to do with the hypothalamic or the pituitary failure. And those are the things that often lead to myxedema coma because they're just not easy to recognize and fix. So next, let's move on to the parathyroids. The most important thing for you to know about the parathyroid gland, since we're going right from the thyroid gland, the parathyroid glands are not at all related to the thyroid gland, right? They are neighbors. They share blood supply and nerve supply and all that, but they are not related at all. They do totally different things. They're just neighbors. You're not related to your neighbors, right? But you live there, you use the same water supply, you use the same electrical lines and all that. The same is true for the parathyroid glands. So one of the challenges in doing thyroid surgery is the fact that they are neighbors, right? So these are two of the parathyroid glands that are shown here. And you can see it's very, very difficult to see these with the markings that are here. This one sort of stands out, but this one is sort of buried in there. Like, how do you even see that when you're operating in there? I don't know, because I don't operate. So what does the parathyroid gland do? Well, it's responsible for calcium metabolism. So in response to the serum calcium level, the PTH either goes up or down, right? And that has an effect on the bone, and it has an effect on the kidneys. Hyperparathyroidism causes inappropriate PTH secretion, or parathormone. That's the way that we refer to it when we talk. And that modifies the amount of bone reabsorption and GI absorption of calcium. Secondary hyperparathyroidism is caused when there's a problem with the PTH, right? And that often happens in chronic kidney disease or in gut malabsorption of calcium. Remember, the best calcium for us to measure in the bloodstream is the ionized calcium level. Ionized calcium means that it's Ca2+, floating around in the bloodstream. And when it's an ion with 2 available electrons, that means it's searching for something to hook up with. Other calcium that's in the bloodstream that's measured in a comprehensive metabolic panel, that calcium is made up of both the ionized calcium and also calcium that is dissolved in the serum proteins. So the important thing about that is if the calcium is dissolved and associated with those serum proteins, those 2 electrons are not available, right? Because they're already being used to hook up with the serum proteins. And that means, though, that calcium is not metabolically available for, muscle contraction and nerve conduction and all that stuff. So we don't look at the serum calcium when we're worried about calcium for metabolic processes. We look at the ionized calcium. Always best to do the ionized calcium. Okay, this is hypoparathyroidism. You can review that. And now let's move on to the hypothalamic pituitary adrenal axis. Remember that there are 3 different hormones that are produced by the adrenal glands. There are glucocorticoids that come from the adrenal cortex. So we call them corticosteroids or glucocorticoids. And the primary one that we produce is cortisol, but there are others that happen as well. There are mineralocorticoids that get produced inside the adrenal cortex, all right? Inside the adrenal cortex from the inner layers. These are important for the reabsorption of sodium and the excretion of potassium in the kidneys. The other hormone that I don't show on here comes from the medulla, the inside of the adrenal gland, and this is where the catecholamines are produced. So let's talk about glucocorticoid control. Well, remember we have this same negative feedback loop that we had talked about before. The positive feedback loop is where there's the hypothalamic CRH that gets sent to the pituitary gland. The pituitary responds by producing ACTH. That sends the hormone out to the circulation, and the adrenal cortex picks it up and produces cortisol and the other glucocorticoids. Then there's a negative feedback loop. When the amount of cortisol is just right, then the hypothalamus slows down production of CRH, and the anterior pituitary slows down production of ACTH, and that's what maintains homeostasis. There's also an aldosterone feedback loop. Remember, aldosterone is a mineralocorticoid. All right, it's a very important thing to remember because aldosterone has a very important role, and you're going to see it when you're treating aggressive hypertension. And even if the patient doesn't have hyperaldo, you may find that they respond to an anti-aldosterone medicine like spironolactone. It's an interesting thing that I've seen clinically for some time. And for these really aggressive hypertensives that you have on 4 or 5 medicines already, you can often add Inspra or spironolactone and get a really nice reduction in the blood pressure to the point where it's just normal now on fewer medicines. All right, all that to say that we can recognize aldosterone problems like an aldosteronoma when there's a disagreement between serum sodium and the serum potassium. So when the serum sodium is up and the serum potassium is down, that should make you immediately think of aldosterone. Okay? So in a situation where you have a hypertensive patient who comes into the office, they very often have low potassium. Even if they're not hyperaldo, they often have low potassium. And if they also have a high sodium level, 150 or whatever, and a serum potassium of 3.2, and they're hypertensive, then they require workup for hyperaldo. The adrenal hormones that we just talked about are shown here, and don't forget the aldosterone is a mineralocorticoid. So the medullary hormones that I mentioned before, epinephrine, norepinephrine, those are the catecholamines. Now, you got a little introduction to this with the case study 2 weeks ago. Cushing's disease or Cushing syndrome is a hypersecretion of cortisol, whether that is, a high amount of cortisol circulating, whether that is hypersecreted by a tumor in the adrenal glands, or whether that is an exogenous amount. They still produce these Cushingoid features. This is the same child, one with Cushingoid features and the other without. So adrenal cortex disorders involve an increase in cortisol due to Cushing's. We call that Cushing's disease or Cushing syndrome. Hyperfunction that increases androgens and estrogen, which is something else that are initially produced or influenced by the adrenal glands. And then hyperfunction that increases aldosterone, and hypofunction in the adrenal cortex that causes Addison's disease. We butcher these terms all the time. We try to say that Cushing syndrome is excessive cortisol levels regardless of the cause, and Cushing disease is overproduction, some hormonal abnormality. And Cushing-like syndrome is from exogenous administration of glucocorticoids, but we butcher these all together, and people use these terms synonymously. So you have to just understand what the underlying process is. The Cushingoid features are shown here, and you should know those. I do want to spend a little time talking about hyperaldo because I think, although it's pretty rare, the effects that we see from aldosterone are becoming more and more important in the management of heart failure and hypertension. And since every nurse practitioner is going to be dealing with hypertension, and every bedside nurse and nursing student are going to deal with hypertension, I think it's important for you to understand how complex this disease is, but yet how treatable it is too. When there's hypersecretion of aldosterone, that leads to increased sodium resorption, right, in the kidney. And that causes more potassium excretion. So we often see, or every time when we have hyperaldo, we see hypokalemia. But even if there's not true hyperaldosteronemia, hypertensives often have hypokalemia as well. And that should make you think that they may respond to an anti-aldosterone medicine. As that sodium gets reabsorbed in the kidney, that causes more plasma volume retention, which causes hypertension and also suppresses the renin-angiotensin system. All of these things together make hypertension worse. Okay. Two forms of hyperaldo. There's primary, where there's some adrenal adenoma that's producing too much hormone, or there's some other in secondary hyperaldo, there's some extra adrenal stimulus, and the book mentions that angiotensin 2 may produce that, may be the cause of secondary hyperaldo. Now let's talk about the opposite. Let's talk about Addison's disease. So this is where there's a lack of mineralocorticoids like aldosterone. And so what do you think is going to happen there? Well, we're going to see an increase in the serum potassium. And remember, in aldosterone problems like Addison's disease, we're going to see the serum potassium go in the opposite direction as the serum sodium. Well, what do you think happens when the serum sodium goes down? Well, what happens is you lose fluid, right? So these people are profoundly dehydrated. They have massive hypotensive problems, postural hypotension, and then, of course, the classic chronic findings of bronze pigmentation of the skin and changes in body hair distribution. But you can put that whole picture together if you think about what happens with aldosterone. This is the anti-aldosterone syndrome, Addison's disease. It's a lack of aldosterone. So with a lack of aldosterone, there's going to be tons of sodium loss in the kidney. Remember that aldosterone problems cause the sodium and potassium to move in opposite directions, so you would expect hyperkalemia. But as the serum sodium goes up, the fluid flies out of the kidneys, and that causes postural hypotension, weight loss, fatigue, massive dehydration, vascular collapse, etc. Okay? This is all laid out for you here as well. There is a primary and a secondary form of hypercortisolism. Secondary hypocortisolism is caused by that dreaded clinical scenario where somebody's on glucocorticoids for a long time, more than a week or two, and they're at a high enough dose that it's suppressing ACTH production. And then you stop the exogenous corticosteroids, and then or the glucocorticoids, and then then the adrenal glands just fail. There's no production because it takes time for that feedback loop to kick in. It takes a few days for that to even start to kick in. So that's why we wean glucocorticoids when we put somebody on them. All right. The classic thing that everybody in any nursing school in the U.S. knows inside and out is pheochromocytoma. It perplexes me that we spend so much time teaching undergraduates about pheo because I've seen it one time in my entire career. One time. It's supposed to have an incidence of 1 in 1,000 hypertensive patients. I've treated thousands of hypertensive patients in my career. I've seen it once, like one time. So it's, I think it's given way too much attention. Is it important? Of course it's important. But are you going to pick it up as the nurse taking care of the patient? Probably not. But the time to think of it is when somebody has these cycles of hypertension, diaphoresis, tachycardia, palpitations, terrible headache, all that stuff. And then, an hour later, they're back to normal again, and this just cycles this way. You should think about pheo and do the pheo workup.